Hi guys! Welcome again to my channel, and today we're gonna talk about becoming UKRN. Basically, these are things that you should know about and things that I wish I knew before coming here in the UK. I'm not an expert. I've just been here for 16 months as a UKRN since I was lucky enough to be in the toughest surgical ward in the universe. So might as well just share it to you so that at least you have an idea, at least you can prepare for it. When you come here, your uniform will be provided to you by the trust. So the dress code follows standard infection control precautions. For example, your shoes, it should be leather or rubber, black in color, and it should be a material that will protect your feet from any blood spillages or any fluid spillages, preferably but not so strictly, without shoelaces. This is an example, and a lot of nurses here are actually using the shoes. This is my shoes. It's Skechers Goga Max, and it's a really nice shoes and it's still working very fine. Thank you, Skechers. This is not sponsored, but second one is the hair. It should be tidy and off the collar. I have this thing that I ordered from China. I know in the Philippines we have so many of this and we use this since we were nursing students. You should bring one of this here because we can't see anything in the store here. And bare below the elbows, so no wristwatches, no bracelets. You can wear your wedding ring, but I'm not sure with the engagement ring. Other rings are not allowed. No fake nails, no nail varnish. And also your uniform, you're not allowed to wear it in public. It's part of the NMC professionalism. Your work hours depend on your assigned area, but it is usually a 12-hour shift, either long day or night shift. Long day starts from 7:30 in the morning to 7:45 in the evening. You will work 3 days in a week, but there is 1 week that you need to work for 4 days, and that will be a total of 13 days in 1 month. And if you're already allowed to do overtime or what we call bank shift here, then you can in between those days. When you arrive here, you will be given a few days time to get settled in your accommodation, and there would be a designated date as well for you to go to the bank so you can process your bank account. It will just take a few hours. You will have your card already. The next week after that, you will have the induction period. So this is like a classroom sessions where you will be meeting the chief nurse, the head of nursing, and all those people. It includes orientation, basic trust policies. You will do some basic training as well. The following weeks after that will be your OSCE review. It really depends with your trust. When I had my OSCE review, I was doing it for 4 days in a week, and then 1 day I had to work as a healthcare assistant. And you will be working as a healthcare assistant until you take your OSCE exam and get your NMC pin. The job of a healthcare assistant is really to assist the nurse. So it includes washing the patients, feeding patients, giving commode or bedpan, emptying catheters or stoma bags, checking blood sugar and observations, or what we call vital signs in the Philippines. Anything that the nurse will ask you to do for the patient. Once you pass the OSCE, you will have your NMC pin and you will start to look after a bay of patients, usually 5 to 7 patients in a bay. But before this, you will have supernumerary days wherein you are really not part of the staff, but you are there shadowing a nurse. She will be teaching you what is the routine, and that will help you to be more confident when you are doing your own bay already. So the usual UKRN routine for a long day, usually 7:30 to 8 a.m. is the handover. This is where the night staff will hand over the patients. When you're doing the handover, you have to be curious. You have to ask questions, and it's good to ask yourself these questions. Were the medications given during the night, and also the early morning medications if it has to be given by the night staff? Should I be concerned about a patient's observations or news score? Do they need fluid balance? People will need to be monitored for their fluid balance if they are on catheter, they have IV fluid running, they have stoma bags, drains, are they septic, and there's a lot more. How's their mobility? Is anyone bedbound? Is anyone needs assistance? What is the current plan of this patient? Like, why is the patient still in the hospital? And then from 8 a.m. to 9 a.m. you will be doing your medication rounds. Sometimes if the medications were given by the night staff, you can wash wash patients together with your healthcare assistant. You have to make the bed and make sure that it is clutter-free, the tables are clean, bedside oxygen and suction are working. And then from 10 a.m., usually we do the observations or the checking of the vital signs. If there are abnormalities, you have to make sure that you inform the nurse in charge, inform the doctors. And then from 11 in the morning, usually there is a huddle. This is like a meeting with the nurse in charge and the other nurses. What is the plan for every patient? What are the things that were done already and things that were not yet done? Anything that needs to be communicated within the nursing team. 12 to 1 p.m. is the lunchtime, and you will be also doing the medication rounds. And then 1 to 5 p.m. is usually your own lunch break, and this is the time that you carry out doctor's orders and other nursing procedures such as wound dressing, suture removal, making referrals, admission, discharge, and a lot more. From 5 p.m. to 6 p.m. is another medication rounds, and from 7:30 p.m. to 7:45 p.m. it will be your handover, and then you will go home. For the night shift, there's not a lot of drama during the night, but the things that is like a routine procedure that is done at nighttime is CD check. So CD is controlled drug check. You will do it with one registered nurse. They will count the medications, sign the CD book, check for discrepancies. One registered nurse will check the crash trolley, making sure that it's functional, up to date, complete. Aside from the usual routine, there are other things that you will need to do that will make your life really busy. You'll be running like a headless chicken. And this would be things that I will be mentioning, but it's not limited to this. There's just a lot more, but this is just example. So one is wound care and dressing change. It's the nurses who does it, and it will depend on how the wound is. Some wounds are just okay to be managed. Some wounds are not. Some wounds are weeping and it needs aggressive clean, aggressive irrigation, and that's gonna take a little bit more of your time. There would be NG tube insertion. Yes, nurses do it. We insert the NG tube, but that is after the training. There would be NG feeding as well, but before you do that, you need to order a machine. You need to check the pH level, and sometimes the doctors will ask you to remove the sutures or remove clips, and that's a nursing job as well. Answering phone calls from relatives. There could be other people who are a bit demanding, more demanding than what the other people are, and it's gonna take a lot of your time, but that's part of your nursing life. There would be also drain or catheter removal. That's our job. Filling up district nurse referrals. Giving controlled drugs, it takes some time because you need to look for another registered nurse to do it with you. You need to write it down on the CD book, give it to the patient together with the other registered nurse, and yeah. Changing stoma bags and cleaning the patient when the bag leaks. It doesn't happen to all wards, but in a surgical ward where they have upper GI, lower GI cases, there would be some stoma bags, and most of these patients have this bag very fresh and very new, so it tends to leak. They don't know how to manage it, so it is us nurses who will need to manage it, and we need to empty it, we need to change it if it needs changing, and it doesn't really smell good, but it's just about getting used to it. There was one time when I asked a healthcare assistant to empty the stoma bag, and he was like, just let me do anything except from emptying a stoma bag. Whenever you're doing this, emptying stoma bags and everything, make sure that you don't offend the patient because they feel bad already about it. It's a new thing for them. It's a struggle for them to accept it, and you have to make sure that you are there to help, that you are not being fussy about it, and we are not here to make it worse for them. Genuine patient care. We all have that, Filipino nurses. We are very good with caring for people. Giving enemas, sometimes it takes time for me, especially for patients who are not very mobile. When you give the enema, you will be expecting that they will ask for a commode, or they will be opening their bowels in the bed, and you will need to clean them. Filling up admission papers and doing nursing assessment checks for new patients. Discharging a patient and chasing doctors for discharge summaries. And another thing, when you have a dementia patient and they usually get a little bit confused, you will need to keep following them to make sure that they don't get lost. For dementia patients, you have to reassure them, reorient them that they are in the hospital and this is your situation. They are just confused. They don't know where they are sometimes, so they could be a little bit naughty patients. Let them walk if they can, but you also have to keep on talking to them that this is their bed, let's go to your bed, let's go back, you're in the hospital, and blah blah blah. If the patient gets aggressive and things like that, you will need help from other people, and there would be a process causes deprivation of liberty and all those. You will learn about that when you come here. And aside from all those things that I have mentioned, there's just a lot more than that. Those are just examples. Number 1 is controlled drugs. Some of these drugs could have the same name but different mechanism or different action. For example, oxycodone, they have modified release, which is the slow release, and oxycodone immediate release. Whenever you give this kind of medication, you have to make sure that you're giving the right kind of oxycodone because it's a common mistake. Sometimes pregabalin is given instead of gabapentin, and I think it's because they sound alike. You have to be careful. Double, triple check. Number 2 is blood administration. You have to make sure that it's the correct patient. You have to monitor them as well. Before you collect the product from the blood bank, you have to make sure that the patient has an IV cannula that is patent and working, and a working infusion pump, and observations are checked. So you have to strictly check the observations 15 minutes after you started and do another set of observations after it is all finished. Next is bedbound patients or patients who are with limited mobility and they're underweight. These people tend to be really bony, and that's where the pressure ulcer develops. So you have to make sure that you reposition this patient, keep everything dry and clean. They have to be in an air mattress. Number 4, diabetic patients on insulin, because they are high risk for hypoglycemia, which is life-threatening, and or hyperglycemia. If left untreated, they might go for diabetic ketoacidosis, which is also life-threatening. Make sure that their blood sugar is just within the normal rate with their insulin, because if it's changing, you have to escalate it. So number 5 is post-operative patients. You have to monitor these patients closely because they are prone to complications and deteriorating sometimes. Observations should be checked regularly. It depends on your trust. The duration, if it's every 30 minutes, every hour. Number 6 is possible septic patients. So whenever a patient is having fever, or it could be without fever but he is breathing faster than normal and he will look like he is not okay. And what I usually do, I check their observations, and sometimes their observations, blood pressure, heart rate is okay, temperature is sometimes okay, but if they don't look right, then they could be septic. They will also sometimes say that they don't feel well. I checked on the blood results for infection markers. Usually it's the CRP and ESR, and if it's abnormal, you have to make sure to inform the doctor to ensure that they have prescribed antibiotics, and you have to give it as soon as possible. We don't need to delay a treatment for this because patients who are having sepsis could deteriorate very fast. And number 7 is DNA CPR, or do not attempt cardiopulmonary resuscitation. You have to make sure that you know who are the patients who are in this status and who are for resuscitation, because if that patient deteriorates and you activate the crash call and everyone coming in resuscitation, and then you find out that patient is DNA CPR status already, then you're gonna be in big trouble. It's gonna be a serious incident. It just means that you didn't respect their decision, and some people just wants to die in peace and not have all those resuscitation drama. Is there someone who is not eating or drinking well, or they are having significant weight loss? You have to refer them to dietitian and to start food chart as well. Does the patient has a serious wound and you don't know how to manage it, or it's not healing? Make sure to make a referral to TVN or tissue viability nurse. Is the patient still with pain despite all the painkillers being given to him or her? You need to refer to pain team nurse. Is the patient diabetic and is having constant low blood sugar or constant high blood sugar, or basically the blood sugar is not being stable? Make sure to refer to diabetes specialist nurse. Diabetic patients are prone to gangrene, so you have to take care of their feet and escalate or refer for any wounds on the feet. Is the patient having swallowing difficulties? You need to refer to SALT or speech and language therapies. Sometimes they may look normal, laughing, smiling, but when they drink, sometimes they cough after, or it's like a wet voice, like when they talk after they drink, it's like something that is still in there. So they are prone to pneumonia, and we don't want that for a patient. Do you think the patient's health condition has changed? Does he live alone? Do you think he will need carers at home? Refer to physiotherapists and occupational therapists. Is the patient going home with surgical wounds or catheter? You have to make a district nurse referral. So that's it, guys. I hope you learned a lot from this vlog, and I hope you subscribe to my channel. If you have questions or anything that you want me to talk about, please comment down below and I'll try to do it on my next vlog. See you guys. Bye. Follow me on TikTok as well.